ahead and get started. Here, I'll go ahead and start today. So this is kind of a cute case, and I don't have a full chest CT. This was done on a cardiac scan. Let's see here. And this is a patient that was scanned, and what we see is this thing right here, soft tissue that appears to be extending into the interlobe, the oblique fissure here on the right. And if you look at it, it's very low attenuation. This is the full field of view image from the cardiac scan, and it comes all the way down here to just where the IVC plugs in. But you put a region of interest on it, you get water. So I think this is just a pericardial cyst that's got sucked into the fissure here. And I don't know if we've seen one of these before or talked about, but I remember hearing about pericardial cysts that could flop around a little bit. I know they change shape.
Yeah, this is a really nice demonstration. I've got like 2, maybe 3 cases of it where it's on a little stalk that allows it to move into the interlobar fissure, which is nearby by virtue of location. And it's soft, so it kind of assumes the shape of the fissure, becomes squashed.
You wonder.
So that is a classic presentation of a mesothelial cyst in that location going into the fissure.
Mm-hmm.
Very nice.
Kind of cute, yeah. And
the thing is, it's extra pleural, even though it's in the fissure.
Absolutely, yes, absolutely. It's not intrapleural. It's just exactly. It's between the 2 visceral pleural layers on the extrapleural surface.
And the amount of protrusion can vary. So sometimes if you have multiple CTs by chance, it may be in one day, not quite in another day.
Right.
Yeah.
Yeah.
Very nice.
Yeah. I don't remember if I showed you this case or not. I don't think I did, but this was something really cool we saw here. So this patient developed this, I think it was a GI cancer, but got chemotherapy, and then this was just a follow-up CT, and you can see the thymus is calcified. And so, I had only heard of this one time. I'd never seen it before. And it has been described after chemotherapy, but before the patient developed thymic hyperplasia. I'm just curious. It's kind of cute. It's just this amorphous-looking calcification all throughout the thymus.
Wow.
I've seen a case before that Leif showed me that was not in the context of chemotherapy or oncology, and I'm trying to remember whether, because it was new, we ascribed it to a stress kind of atrophy, because I think the patient was a burns patient. We were speculating whether the stress of the burns and prolonged hospitalization resulted in that. I'll have to bring up that case again to see if I can find it, because I think it looked just like this one.
Jeff, there wasn't any calcium in spleen or in the adrenal gland or anything like that, was there?
No. See, nice and pristine.
And there wasn't renal failure.
Nope.
Okay.
Nope.
That is so interesting.
So I'm waiting to see the next one, because the one case report I came across talked about it preceding hyperplasia. So if there's a rebound phenomenon, if we see this, if it's sort of an acute involution that then leads, I don't know. I don't really understand. I don't think anybody understands it, but it was just odd. I'd heard of it. I'd never seen it before, and that we just happen to have a case. All right. This is a kind of a cool heart case. And so this patient had pulmonary hypertension and has an interesting shunt. So what we have here, if we come down, is we can see there's a communication between the right atrium and the left atrium inferiorly, and it's right at the coronary sinus. This is an unroofed coronary sinus that we see here. And so blood is coming from the left atrium back in the right atrium. Of course, if you get an Eisenmenger, it switches direction. You can see there's RV thickening, dilation, so a good case of pulmonary hypertension. But what I think is cool, and I don't have any other imaging, this is an older case, is there's this vessel right here that passes in front of the left superior pulmonary vein that's dense contrast, as dense as the SVC. So I think this is a persistent left SVC that drains into the left atrium as well. And you can even see a little contrast pooling there.
Oh, so a left SVC draining to left atrium.
And you can see there's the mixed
unroofed coronary.
and then an unroofed coronary sinus.
Yeah.
With
There
almost
is
almost like an inferior sinus venosus type ASD.
Yeah.
So it's
I stand to be corrected, but there is a syndrome called Ragib, something like RAGH.
Ragib syndrome.
That I think is this constellation of findings, if I remember correctly.
I asked one of our cardiac people about that, and he said it was slightly different. That with that one, instead of having an unroofed coronary sinus, you have atresia of the coronary sinus. But I think physiologically it's identical. But yeah, I'll have to look into that. It's curious, but it's kind of a cool case. But it's a nice example where a lot of times when you get these funny drainage communications that it's just you may have another one in there, and there really shouldn't be any vessel up here. And then this mixing artifact is sort of a tip off that there's some undiluted contrast coming in. All right. And speaking of flow dynamics, this is kind of a crazy case that my fellow Brad shared with me. So I had to wrap my head around this a little bit. So this is a PE study, and if you look at the contrast, you can see there's contrast in the SVC, there's contrast in the aorta, and then there's what looks like no filling of the pulmonary arteries. We have retrograde flow down the azygos somewhat, dense contrast in the right heart, and then this little bit of contrast along the mitral valve leaflets, and then all this unenhancing lung, and then this crazy looking abdomen where you've got contrast in the hepatic veins. And then this is actually in the renal veins right here. And so this is a patient on ECMO who's asystolic and probably was asystolic at the time of the scan. So this is here's the abdomen. You can see the nice retrograde flow into the renal veins, giving you a renal venogram. But this patient was on you can see there's the ECMO catheters coming in right there. You got an arterial one anteriorly and a venous one posteriorly. So you've got blood coming in one and out the other. So presumably this is just related to the asystole. And so contrast is pooling, probably dripping down the mitral valve leaflet and accumulating in the left atrium through a regurgitant or incomplete coaptation of the valve. It's just a weird flow dynamic. I think Travis showed that case of an asystolic patient one time. And, the question is this big thrombus or not? But I think this is probably more just unopacified blood with some mixing in. But it's hard to know if there's stasis there or not. Have any thoughts about this, but trying to figure out what's going where is kind of tricky, because I can't remember CTing anybody on ECMO before. So
yeah, there is yeah.
So this is like smoke at its extreme. So so this patient they weren't able to resuscitate, so they did this looking for was it pulmonary embolism and any reason not to be alive effectively, but so a CT and asystole.
But no, there wasn't any post-mortem exam to determine whether there was thrombosis of that.
If it is
from PA,
not at this point, there may or may not be.
Okay. The thing that really kind of worries me about that possibility of clot is it seems to have a rounded anterior margin.
Right, and we sort of talked about that. Like pulmonary sarcomas will do that.
Right.
There may be some thrombus, but could there be a big tumor there? Maybe. It's really smooth though, but I think that's a good point, David. So, well, I will have to look into it to see if they're going to pursue a post-mortem, but if so, that could be very enlightening.
Wow.
Okay, that's what I have this week. All right, who would like to show a case or two?
I've got a couple.
All righty.
No, here's a youngish guy who has HIV. I think, from what I know, this is a fairly recent diagnosis. I think he's been on therapy, but it's not been compliant. And things, he got short of breath a few days later because he has diffuse lung disease. It seems to be basal predominant. And then I'll bring you closer to current imaging. It's not going away. You can see it's getting denser and denser in the bases here. He's intubated. And, you know, this is PJP. So this is pneumocystis. And the thing that's a little unusual about it is the basal predominance. But I remember the days of swine flu. The cases that we saw of swine flu, this is around 2009, were mostly apical predominant at the beginning, which is good for viral infection. It's also good for pneumocystis. But with time, the densest consolidation was in the bases. And I think that's as the secondary complications of the pneumonia and the secretions begin to pool in the bases that the burden of apparent lung disease shifts to the bases. But I think that the infection itself starts in the apices. I'm just wondering if that's true in this case as well. I don't have a CT scan in this.
Could it be just developing alveolar damage, and we're starting to just see, you know,
accumulation of crud?
Yeah, just inflammatory cells, more blood, leaky capillaries, and
right. So pneumocystis, I don't have a CT. Maybe we'll get one. He doesn't seem to be responding that well to therapy, so I don't know what more they're going to do. Okay, I hope that I'm in order here. Let's see. Okay, so here's a I showed you guys some dog specimens before, and this person, this is a human, looks surprisingly canine. This thoracic deformity here with this elongation, respectable, you know, position of the diaphragm down here, gracile, long bones here. This person has a condition called spinal muscle atrophy, which is a neurologic condition that I just started to read about this morning. And this person's had recurrent, pneumonias and aspiration and atelectasis. But the position of the diaphragm is quite good here. This person doesn't look like somebody who can't move the diaphragm. And here's what CT looks like in this person. There's not much in the way of paraspinal muscles here. Sorry about all the artifacts coming off of this spinal hardware here. But there's very little chest wall musculature. And in particular, there's not much in the way of intercostal muscles. And I think with that muscular defect in the chest wall, that's why we have these rib deformities that sort of collapse inward here. The negative pleural pressure of the lung is actually pulling the chest wall in, and we don't have intercostal muscles that assist in breathing. But from the Wikipedia reading I was doing this morning, the diaphragm tends to be spared in this condition. And this person, I think, is in her 30s at this point. So I think if there were diaphragm involvement, there are different types of this. Hers is type 2. She wouldn't have survived to this age. She's able to get around in a wheelchair or be conducted in a wheelchair. She's able to breathe pretty much on her own. She's not always had the tracheostomy tube. And she has, although we're not seeing much of the cruise, she has respectable muscle thickness down here. So in this condition here, her diaphragm is spared. She does have respectable cruise thickness, although we're not imaging it as well as I would like. But she's lost these chest wall muscles, including intercostal muscles, which is typical. So her breathing difficulty is largely her intercostal muscles not working very well. Okay, so and her lungs, the CT scan was done at a different time from that acute right-sided consolidation that you saw sitting in this area. You can see that she's got some basal scarring down here, probably from previous aspiration events and things like that. Okay, so actually able to survive without being on a ventilator, despite the profound skeletal muscle problem that she has. And then the other case I wanted to show you was this man who has got very low lung volume and has a lot of, this is our earliest radiograph on him with basal consolidation, I think thought to be aspiration. He had a rough hospital course, this is back in 2015. And CT around that time, this is a few weeks later, he has at this point pleural effusion. He's got some patchy lung consolidation, mostly mid-lungs and bases. Looks as if he's got a bronchiolitis pattern down here. And he has no chest wall muscle. And his paraspinal muscles have pretty much just turned to fat. And his diaphragm is almost inapparent. So here's a little bit of diaphragm. Here's a little bit of crus that we're seeing. This is, don't mistake this pleural effusion for crus. Here's the actual crus itself. You can see it's way thin and wispy. So this fellow has Duchenne muscular dystrophy, and he does have diaphragm involvement here, which is why his lung volume is so low. So this is the best, the clearest set of lungs I've seen on him. This is from 2016. He's got just a little bit of residual stuff down here. And on lateral view, you can see that he's got high position of both heavy diaphragms, and it's a shallow arc that goes all the way back, which is good for weakness or paralysis. As opposed to say eventration, where it tends to be steeper and plunged to normal level posteriorly, this one stays shallow arc all the way back, elevated all the way back to the posterior chest wall. And we don't have a later CT on him. This is the current imaging on him with lower lung volume and more left basal stuff. This is the current admission. He's on a ventilator, or he's being ventilated at this point. So he's got Duchenne, and he does have diaphragm involvement. The lady with the spinal muscle atrophy has lost a lot of her chest wall muscles, but has preserved her diaphragm and has much lower position of her diaphragm because of that. Okay, those are
all right.
Yeah. Thank you.
All right. All you heard.
All right. So this is my really interesting case of the week. The other two, not so much. Looking at this the other day, there's quite a few patients here on different forms of support devices for cardiac. And of course, this patient has an intracorporeal left ventricular assist device. We can see the patient has a CRT-D device, has had surgery with the left atrial appendage exclusion device, is currently ill in the hospital. So I was looking at all that and recognizing all the usual things that I was going to observe and describe. And then I noticed something that I didn't expect to see. And it's a little hard to see here, so I'm going to mag it up. And initially I thought it was a fake out, but when I magged it up, I said, oh, wait, that's real. And then, like, what is this and why is it there? In that location. So I started looking some more and found this from the previous day. And this is just one series that I have saved. And indeed, this is the time in which they deployed that device. And there it is. And if you were thinking that is this a septal occluder device, because it has the usual appearance where there's sort of two discs parallel to each other, you're absolutely right. But what's it doing there? Does that make any sense? And it didn't make sense to me until I found out some more information, which took some time. So this is something that I didn't know about before, but it turns out that some patients who are on left ventricular assist device for some period of time develop, and I don't think anyone understands that very well, but some of them develop very substantial aortic valve insufficiency. And you can find a bunch of case reports about that and articles about that now. So there is the notion going here that this is definitely a problem for some people and can progress. And of course, if you have huge AI, then you're basically expelling blood into the aorta, and a good portion of it comes back. So that's not a good situation. And that's a known thing. I didn't know about that. Sorry about that. Let me just bag it up this way, so you can see it right there. So then the question is, what do you do about that? And people have tried different things. But in this particular person, what they were trying to do was use off-label the atrial septal occluder device and atrial septal occluder device to basically, sorry about that, effectively occlude the valve and diminish the aortic incompetence. So they were partially successful only. And reading the ultrasound report, the amount of insufficiency diminished somewhat after deployment of the device, judged by transesophageal echo, but they've left it in place. So I think some people have put an actual device there, like a TAVR valve, and I don't know about the merits and the demerits of all those kinds of things, but people have used an Amplatzer device. I think this one is called a Gore cardioform atrial septal occluder device, and the cardiologists seem to indicate they tried this one because if it didn't work quite right, they could still take it away, because there's something about the way you deploy this that it's not fixed, that you can remove it if it's completely unsuccessful, as opposed to just leaving it there. But I'd never seen that before. That was quite new to me.
Yeah, that's
they were trying to
Can you go back to the fluoroscopic image? What is that a microangular thing? That's, yeah, what is that?
I don't know if that's another valve. I can't tell. It shouldn't be in the aortic position. I don't know what that is.
Because I've seen devices, I didn't know they used them, but for a while there was this device they were testing that they would put in the mitral. It's like a type of mitral annuloplasty. I was wondering if that's what.
I think that's probably what it is. I'm going to have to check on that, because that's a really good thought, because they've got this atrial appendage exclusion device, previous surgery, and that's a good position for a mitral thing. So that's a separate thing, though. But that's a good thought. Yeah.
That's strange.
Yeah.
It's funny, so when you showed the radiograph, I thought it was just one of these, these new aortic valve prostheses are getting harder and harder to see, and I thought that maybe that's what that was.
No.
Yeah, now you can see it, the squiggly stuff.
Yeah.
Cool.
Yeah. So I didn't know about that entity.
So what does it do?
Google, you can find case reports.
Weird thing do.
Pardon?
Jeff, what is that strange device supposed to do? It's in the mitral position. What is it doing?
It's a form of annuloplasty to sort of alter the shape of the mitral annulus to help the valve coact better.
Good thought. It may be that exactly. I'll try and find out and let you know. I have to look more in the chart. I didn't see a mention of that, but I could have missed it, of course. So, off-label use of an atrial septal occluder device to try and diminish the severity of aortic insufficiency, complicating long-term LVAD patient.
You can, Howard, I think you can see that it would be useful to do that for the mitral valve, because that might have been insufficient too, and also wasting the output from the LVAD. So maybe they went after both at the same time, both aortic and mitral valves.
No, I'm pretty sure that there wasn't a recent intervention involving the mitral valve for that reason.
All right.
I do know that this was put in for the AI, that I was able to briefly discuss with a surgeon, with a cardiologist. Interesting. This is I'll do this one first. This is really an unfortunate person. One can't make a diagnosis without context. You see a radiograph, it's labeled trauma. Patient does have a cervical collar, has got a defibrillator device on the chest, diffuse lung opacity, some sparing of the right side, Certainly predominantly alveolar consolidation. Perhaps there's a peribronchial fluid cuff or two, but certainly predominantly alveolar consolidation. And I'll show you a little bit later on the same day. Intubated, things are not doing well. And now you see it looks like that. This is the, again, a bit later on the same day. So this is unfortunate. A person tried to commit suicide by hanging. She was found by someone. They were able to get her down and she's still alive. But certainly when one sees that, and in that particular context, a very reasonable diagnosis is acute airway obstruction related lung edema, sometimes in terms of pathogenesis called negative pressure lung edema, where tremendous negative pressures, pleural pressures, are transmitted to the pericapillary interstitium of the lung, so that according to Starling's forces, water is drawn out of the capillaries into the lung, producing lung edema. Usually we see that, I think most commonly the cases I've seen, which usually resolve quite promptly, are in the context of anesthesia. So in the anesthesia recovery room, when people develop laryngospasm, that's the one that I see most often as a cause of negative pressure lung edema. Now, of course, if she was ischemic for some time, who knows to what extent her heart may be affected, or arrhythmias and the like contributing to this, but certainly consistent with acute airway obstruction associated lung edema in this person. And she's not doing well, as you might expect. This one is something we've seen all the time. I'm just showing it because it's such a nice example of it. And for the patient, it's really awful. So this is a patient with scleroderma. This is a radiograph from 2015, December. This is the earliest CT we have the following month, with imaging findings in the lower lung zones, absolutely typical of NSIP. So we have basal predominant disease, it's ground glass opacity, there is some subpleural sparing, but otherwise in this particular context, absolutely typical of it. And then I'll show you the follow-up, which is the really unfortunate part, because in spite of therapy, this is progressing really badly. So we go down to the lower lung zones. One can see substantial traction bronchiectasis in the lower lung zones. And there's more disease overall in the upper lung zones, albeit patchy with subpleural sparing. And then the most recent one that I have from currently is this one. So the time between these two is that period of time. And there's greater degree of involvement of the upper lobes now. Again, traction bronchiectasis is rather conspicuous, subpleural sparing, and just really progressive in the lower lung zone. So really no differential diagnosis for this scleroderma with fibrotic nonspecific interstitial pneumonitis, very typical, pretty awful for the patient.
Esophageal problems there too.
Yeah, esophageal distension.
Yeah, Howard, that's a nice example where it shows with the traction bronchiectasis you see with NSIP is usually much more central or extensive like this than you see with UIP, where you just see it in the subpleural lung and maybe milder. And you do have that nice relative subpleural sparing on that image on your right, screen right.
Yeah.
Yeah. Sort of, as it gets more advanced, starts to go away a little bit.
Yeah.
That's
just awful to see that in a young person.
It's a nice case.
I don't think the esophageal disease and the rest of it is that bad. She just has terrible lung involvement.
Yeah.
I presume she'll potentially come to lung transplantation. Nothing's going to work and it's pretty advanced.
Mm-hmm. All right.
All righty, Jeff, those are my cases for this week.
We'll finish early today, but